Let him join. Good morning, everybody, and welcome to this Grandround. This week's is going to be internal medicine, and as internal medicine, I think encompasses all the specialties. It should be very interesting. Our guest moderator, Dr. Vijay Mohan, is going to join us shortly, but we'll start our cases now. Dr. Narasimham will, of course, report.
Good morning, friends. And as was rightly mentioned, the mother of all specialties in medicine is internal medicine. And it's very right that we are starting with an internal medicine grand rounds. We'll be shortly joined by Dr. Vijay Mohan, who's currently the professor of medicine at AIG Hospital and a consultant internist at Care Hospital. We have three interesting presentations, and we'll start off with the first case, which is a case of tropical fever with hemolytic anemia. Will be presented by Dr. Ashok Dar.
Good morning, everyone. So here I am going to present a case of a lady who had come to us few months back. After our first rundown, it has been more than 1 year, 3 months. So this is a lady who came with a history of fever. So we'll directly go to the case. The patient profile, she was a 45 years old female, homemaker by profession, a resident of Hyderabad, and recently detected, to be precise 1 month back, to be having hypothyroid and unsupplement. No other known comorbidities, and she was moderately obese with a height of 150 centimeter and 78 kg body weight with a BMI of 34.7, and her dietary habit was mixed diet. So she presented with complaints on 19th of May to the emergency room with history of high grade fever with mild chills, headache, body pain, generalized weakness, all started on the same day, 5 days back, with a duration of 5 days illness. And there is history of traveling to a forest area and trekking there 2 weeks prior to the onset of the symptoms. So initial clinical evaluation was done at the emergency room. Patient was conscious, oriented, sick looking and lethargic. She had dehydration, mild pallor was there. She was icteric, no lymphadenopathy, no rashes or visible insect bite marks on her body. And examination wise, she was mildly tachypneic with a respiratory rate of 22 breaths per minute, no hypoxia, and her saturation was 96% on room air. Temperature was 100 degree Fahrenheit on the axilla. She had tachycardia with a pulse rate of 110 per minute, low volume pulse, and had mild hypotension with a blood pressure of 100 by 60 millimeter mercury on supine position. On examination of respiratory system, it was found that breath sounds were decreased on both lung bases with few basal crepitations, and per abdomen was soft, mild diffuse non-localized tenderness. She had hepatomegaly, which was non-tender, and normal bowel sounds. Other systemic examination were insignificant. There was no abnormal findings clinically. So with a provisional diagnosis of undifferentiated tropical fever, she was admitted, and mild unstable hemodynamics, she was admitted and into the acute medical care unit. So initial evaluation were done. Before the day of visit to the hospital, she had done some investigations, and in the table what we see on 18th, on the left side, that was a day prior to her visit to the hospital, and her hemoglobin was 11.4 on the prior day with an RBC count of 3.6 million, and a packed cell volume of 35 with a total WBC count of 3,500 and mild thrombocytopenia with 1.2 lakh platelets. Dengue NS1 was done, which was negative, and her urine routine examination was normal. On admission, the investigation what we did, we found that hemoglobin was 10.1. In comparison to the previous day, it was a bit less. And her RBC count was 3.2 million with a PCV of 30. Total WBC count was 4,700. And there was severe thrombocytopenia on that day. She had a platelet count of only 15,000, which was reconfirmed from the laboratory with double examination, repeat examination. And plus peripheral smear showed hemoparasites, plasmodium ring forms. And there was derangement in the liver function test with a bilirubin of 8.1, predominantly conjugated with a direct bilirubin of 5.4, and mild increased liver enzymes with an ALT of 58, AST of 76, and ALP of 228. And there was hypoproteinemia and hypoalbuminemia with protein of 5.1 and albumin of 2.7. Renal function test was overall normal except mild hyponatremia of 134 millimole per liter. And other investigations, smear for MP Plasmodium falciparum was found, and the malaria parasite density was 4 plus. That means more than 100 parasite per high power field on examination. And here the dengue IgM came as positive. Other tropical fever panel was sent, out of which leptospira antibody, which came later as negative. Scrub typhus was sent, which also came later as negative. And ultrasound was done on admission, which showed hepatomegaly with fatty liver of grade 1 and gallbladder wall edema with minimal subhepatic fluid. A streak of fluid was there. And ABG showed mild metabolic acidosis, and random blood sugar of 124, and G6PD was negative, and LDH was raised. It was 1043. So this is the initial evaluation on admission to the emergency and to the AMC. Then with all these definitive malaria diagnosis, our obvious plan was to start her on antimalarials. She was started on IV artesunate at a dose of 2.4 milligram per kg body weight at 0 hour, 12 hour, 24 hour, and advised to repeat every 24 hours. Along with that, doxycycline was added as an empirical antibiotic, also an artemisinin combination therapy also. Platelet transfusion was given on the day 1, and other supportive therapy like multivitamins, folic acid, IV fluids, PPIs, and paracetamol for fever was started. During her stay in the AMC, during first and second day, she had some more clinical developments. She had persistent fever, had one episode of vomiting, and 3 to 4 episodes of loose motions. Then with that, she got more dehydration, worsening of tachypnea. She developed mild hypoxia, for which low flow oxygen was started on her. She became drowsy but responding to command. And lab wise, anemia worsened on the second day. From 10.1 on day 1, it came down to 9.2, a significant decrease. And LFT was further deranged, and because of drowsiness, ammonia level was done, which was normal. Renal parameters got deranged on the second day. From a normal creatinine, it jumped to 1.61. She was non-oliviric. Metabolic acidosis worsened further, and in this view, procalcitonin was done, which was found to be high. And due to that, we had sent blood and urine cultures, and LDH level had almost doubled or tripled. From 1000 on admission, it had gone down to nearly 3000, 999, suggestive of hemolysis. Then she was shifted to the ICU for further management. In the ICU, in view of her deterioration, antibiotics and supportive care was optimized. She was put on high broad spectrum antibiotics. Doxycycline was continued with artesunate as an artemisinin combination therapy. Infectious disease department was consulted for further input from their side. And after initial deterioration, After a day or two, her liver function and renal function test started improving, and platelet count also started recovering. But in spite of this, her hemoglobin was continuing to drop and progressively and rising LDH level day by day. And during this, again, because of falling hemoglobin, suspicion of any bleed or hemorrhage was suspected. There was no evidence of any external internal bleed. Stool local blood was repeatedly done, which was negative all the time. And in view of drop in hemoglobin drastically, she was administered packed cell red blood cells. And during ICU stay of 4 to 5 days, her general condition gradually improved, and she was shifted to room after 5 days of stay in the ICU. In the room side, in the wards, so good things happen, and she completed 7 days of artesunate with doxycycline. Malaria test was repeated twice, which was negative both the times. Renal function was restored to normal. There was significant improvement in liver function test. Platelet count was normalized, and keeping on this on view, antibiotics were de-escalated. Hemoglobin level, but on the con side, hemoglobin level continued to drop further. Progressive erythropenia and falling hematocrit day by day. Patient required a repeat blood transfusion in the wards, and LDH levels remain elevated. So this is a gist of the investigation done during her hospital stay, starting from 19th to 24th during the first 5-6 days. We have another table in the ensuing days. As we can see, the hemoglobin on admission was 10.1, and there was gradual drop every day by 0.5 to 1 gram till 8.3. On 23 there was drastic drop, and on 24th it came below 7, hemoglobin dropped to 6.5, and at this point a packed cell transfusion was given, and platelet count was 0.15 lakh first day and 20,000 second day. Here we had given platelet transfusions, and slowly over a period of time it started improving slowly, and by 24th it has reached 1.35 lakh. And bilirubin, as we discussed, there was initial deterioration in the liver function test. Bilirubin had gone up to 9.7, and all the time it was predominantly conjugated hyperbilirubinemia. And there was bit variation in the liver enzymes, not much, not more than 2 times upper normal limit. LDH kept on increasing from 1043 to 2999. Then after 6 days it was 2244. Urea creatinine, as we see, on the first day it was normal, then on 21st it was high, on 22nd it was further high, 1.94 of creatinine with 88 urea, then slowly it also started coming down. During this time, to see any coagulopathy or any intravascular hemolysis or DIC, PTA, PTT, INR was done, which was normal. Stool local blood was again repeated in the ward, it was also negative 2 times. Then on 25th, again the hemoglobin started dropping, improved after giving the transfusion, then further again dropped. Again on 27th, one more transfusion was given. And all things continued to drop, and erythropenia was progressive, RBC count came down to 2.1, and packed cell volume also came down. WBC count after the initial rise, midterm rise, then it settled down. Platelet count became normal. Bilirubin count also improved, and enzymes improved, and creatinine and urea became normal. Again a PTA, PTT was done in between, which was normal. And we suspected whether there is an autoimmune hemolytic anemia. Direct and indirect Coombs test were done. Direct Coombs test was negative, and again repeat malaria parasite was done negative. Then after so many days of repeated investigations, patient requested to give her a investigation free day. So on 29th no investigation was done, and on 30th it was found that her hemoglobin has been stable at the same level of 6.9 with marginal improvement in the cell levels. And at that point of time, because the patient was hemodynamically and clinically stable, it was discussed, it was decided that patient will be discharged on that day. So during this, let us just refresh our knowledge about hemolysis in malaria. So persistent hemolysis in this case, particularly, what might be the cause? Definitely Plasmodium falciparum is there. It is an hemolytic disease, so Plasmodium induced hemolysis will be there. Non-immune, that is direct effect of the erythrocyte. Immune mediated hemolysis due to Plasmodium, whether it is a drug induced hemolysis or there is any autoimmune component. So causes of hemolysis in malaria will go briefly only. Non-immune mediated is the main cause of hemolysis in malaria in the initial days. It results from direct destruction of the infected RBCs which are parasitized by the rupture of the RBC by parasite, and is more pronounced in severe malaria caused by Plasmodium falciparum. And as we saw, our parasite density was 4+. Immune mediated hemolysis in malaria is due to generation of autoantibodies against a variety of erythrocyte antigens, and antigens against cytoskeletal and membrane lipids, proteins, enzymes and sugar moieties, and also antibodies against DNA and phospholipids. Out of these, the most important is antibodies against erythrocyte membrane lipid phosphatidylserine, which has been established a major cause of hemolysis anemia in malaria patients. In this case, non-immune mediated, non-infected RBCs are also hemolyzed by forming rosettes. Drug-induced hemolysis, artesunate has been found to cause hemolysis, though it is rare, but it is not uncommon. The pathophysiology of hemolysis in artesunate is not fully understood, but the most likely mechanism is pitting. RBCs carrying dead parasites, the parasite which has been killed by artesunate, they still remain in the RBC. Then they pass through the splenic circulation for cleansing, and in the spleen the dead parasite is removed from the RBC, and in that place the RBC develops a pit or an indentation, and they re-enter the circulation. But because of the pit, their integrity is impaired, resulting in a shortened lifespan of 1 to 4 weeks, which will be hemolyzed later at an earlier stage, even after recovery from malaria infection. Hence, the term post-artesunate delayed hemolysis or PADH is used in artesunate treated patients. And immune mediated mechanism in artesunate induced hemolysis is also hypothesized, but till now research is going on this to prove and get any evidence. So apart from hemolysis, hemolysis is not the only cause of anemia in malaria. There are varieties of causes of anemia in malaria. We will just go briefly about them. So as we have discussed, hemolysis of parasiticized red cells and hemolysis of non-infected red cells due to immune mediated mechanism, and splenic and reticuloendothelial hyperactivity which further hemolyzed the circulating red blood cells due to increased splenic filtration of infected and uninfected RBCs, and formation of rosettes of erythrocytes, that is parasitized RBC with non-parasitized RBC, which again antigen presenting complexes, the surrounding antigen presenting complexes, they are hemolyzed in the spleen. Other is host genetic factor. Certain mutations, ferroportion mutation prevents hepcidin induced degradation and offers protection against severe malaria disease, which is seen in some African tribes. Tumor necrosis factor gene polymorphism may increase the risk of hemolysis, and bone marrow suppression, multifactorial bone marrow suppression due to erythroid progenitor abnormalities, dyserythropoiesis and erythropoietic suppression, hemojoin induced suppression erythropoiesis. Hemojoin is the pigment in malaria. In the RBC, the malarial parasite consumes the intra-erythrocytic protein, which predominantly hemoglobin, and the heme component of the hemoglobin is converted to hemojoin by lipid crystallization by the malarial parasite, and this hemojoin is specific to malarial species, Plasmodium species. They have a certain color of the pigment. The falciparum hemojoin pigment is black and vivax hemojoin pigment color is dark brown. Other than this, cytokine induced suppression of erythropoiesis and altered iron metabolism due to elevated pro-inflammatory mediators like tumor alpha factor and interleukin 6. So these are other causes of malaria in, other causes of anemia in malaria. So in these conditions, the treatment guideline is usually simple. In case of severe anemia, we have to give blood transfusion to maintain the hemoglobin concentration. And if there is coexisting iron deficiency, we have to give iron supplement. Folic acid supplement is a must, and other supportive treatment. And if the patient is discharged, strict weekly follow-up after discharge with all lab parameters at a regular interval. So our patient was discharged on 30th May with appropriate supplements and was advised for follow-up at the medicine OPD after 3 days. We did not want to wait for 7 days. We asked her to come early because her hematological parameters still were not stable, and she was advised for follow-up at 3 days. So she came after 3 days. We were expecting a bit of improvement in her condition, but there was opposite. The patient came on a wheelchair. She was severely pale, extremely weak, and had to walk with support. She was unable to walk on her own. She had mild dyspnea on walking, but no dyspnea or tachypnea at rest. Hemodynamically, she was stable, and her vital parameters were normal. So she came with her investigation reports, and as we compare her reports before discharge, hemoglobin was 6.9 on 30th, as we can recall, and which had dropped to 4.2. And RBC count from 2.1, it had gone to 1.3. Packed cell volume was severely low, a very low hematocrit of 13.1. And WBC count had gone up to 17,300. Platelet count was normal, and reticulocyte count before discharge was 14.5%, and it had gone up to 20.15%, suggesting severe hemolysis. LDH had almost doubled, 4,600. So hemolysis was severe and ongoing, relentless hemolysis. Ferritin was high, and there was marginal increase in the bilirubin level, and at that time it is predominantly unconjugated, a 4.4 bilirubin with unconjugated bilirubin of 3.2. Others, the enzymes were normal. CRP was 86, on admission it was more than 290, and before discharge her direct Coombs test was negative, but on review visit direct Coombs test was positive. So it gave us a clue that the patient is having autoimmune hemolytic anemia post-malarial. Patient was advised rehospitalization for further management, but the patient did not agree. She wanted to be treated at home, but she was advised against it. She did not agree. She was asked to be on regular follow-up and was advised medication. So as DCT was positive, it was thought about using steroid, and as per evidence by certain publications, recent publication, there has been mentioned by some publication regarding steroid use and favorable response in few similar cases of severe falciparum malaria. So it has decided to start her on steroid. Though her weight was 78 kg, she was started on 60 mg prednisolone per day, and a tapering dose of 10 mg every week over a period of 6 weeks was planned. She was advised to continue supplements and was advised for strict follow-up every week or SOS in between whenever she feels that things are not going well. So on subsequent visits, patient started improving clinically. All lab parameters showed better values on each subsequent visits. She was back to her pre-disease health state at the completion of steroid course of 6 weeks. So here the lab values after her review visit. As we can see, hemoglobin slowly started improving from 4.2 on the review visit to 7.5, and on every week she was coming. And later on, after 27th June, because her condition was stable, she was advised to come after 3 weeks, and her hemoglobin had gone up to 10.2. There was an improvement in RBC count of 3.9 million. PCV from 13, it had improved to 33. WBC count was stable. Platelet count was normal. Retic count came down to normal, 2.1%. LDH came down slowly to a comfortable level of 498. Ferritin became normal in between the course, so it was not done further. And liver function also with due course became absolutely normal with normal bilirubin and enzymes. And in between that, to find out whether other autoimmune conditions she is suffering from, ANA test was also done in between her follow-up, which was negative. And throughout the course of steroid, her sugar was monitored to check that she doesn't develop hyperglycemia or steroid-related hyperglycemia. Her sugar had been stable throughout the course of the disease. So after that visit, she was asked to come after 3 months for a final visit, and she came for the concluding visit of 3 months in the month of October 2022. All the lab parameters were within normal range, and she was advised regarding healthy diet and physical activity and weight management because of her obesity. So our final diagnosis after the concluding visit was complicated falciparum malaria with a parasite density of 4+, dengue with IgM positive, acute kidney injury with hepatopathy which resolved, and autoimmune hemolytic anemia. And the patient vowed not to go for trekking again in her life.
Thank you,
Thank
Dr. We may invite comments from Dr. Vijay Mohan, please.
Good morning. It was well worked up case, Dr. Ashok. Firstly, I want to congratulate you. Well worked up and well studied and very well presented, in fact. You know, there were dual infection. If I missed a couple of earlier slides, dengue you said it was positive, right? IgM was positive, and then malaria. These are dual infection, if I'm not wrong, right? Okay, this hemolysis, as you rightly mentioned, initially, though it was looking like a multifactorial, it could be malaria, it could be drug-induced, but ultimately you narrowed down because the subsequent outpatient visit, patient came with worsening parameters, including hemolytic anemia. So ultimately, the Coombs was, second time Coombs was direct was positive, that clinches the diagnosis of autoimmune etiology, though initially there was a multifactorial thing. Really want to congratulate you. And what is the further course of action? What is the further course of, I mean, in follow-up, what are you going to do?
All of the patient after October, she has visited 2 times, sir, during this period. Sorry, 1 time, on October and once more. But this time visit, just routine examinations were done, everything was normal. Now she is visiting for her hypothyroid.
Okay.
Any questions from the floor? So just to put it in perspective, the person had a malaria, dengue, and then evidence of intravascular hemolysis. There's a brisk reticulocytosis. That's an important sign because unlike the persons who are well nourished, if you go to rural ages where patients are deficient, you won't have a reticulocyte response because they have concomitant iron deficiency, they'll have concomitant folate deficiency. So that shouldn't lull you into thinking that it's not hemolysis. So you need to have overall picture of the whole thing. And very well worked up. Congratulations. We'll move on to the next case, which is going to be presented by Dr. Kiran, a case of PUO.
Good morning, everyone. Today I'm going to present a case of So he's a case of a 32-year-old male hailing from Karnataka. He presented to us on this early January. He's a handloom textile inspector. He doesn't have any comorbidities. He presented to us with chief complaints of fever on and off for 2 months. Fever was high grade, intermittent, associated with chills. There was no evening rise of temperature or night sweats. It was associated with cough with scanty expectoration for 2 weeks. He also had anorexia and weight loss of 2 kgs over past 2 months. He developed upper abdominal pain and jaundice for just 10 days prior to admission to AIG. So there was no proper localizing history. Apart from that, his past personal and family history was not significant. He doesn't have any addictions. So coming to general examination, he was moderately built. At the time of admission, he was sick, conscious. He has high axillary temperature of 102 Fahrenheit. He was tachypneic with respiratory rate of 32 per minute. His pulse was high, 140, and blood pressure was normal, 100/60. His saturation was 90% on room air. So there was also icterus, and other general examination showed small cervical lymph nodes. Largest was measuring around 1.5 by 1.5 in the level 2 lymph node. Cervical lymph. There was no axillary or inguinal lymph nodes palpable. So other systemic examination showed there was palpable tender liver 1 centimeter just below right subcostal margin, and his CVS and respiratory system was unremarkable except for few bilateral basal crepes. So with this brief history and general physical examination and systemic examination, it's a case of prolonged fever with no clue. So PO for evaluation, what a physician would think of is are infections, commonly tuberculosis, especially disseminated kind, and retroviral disease is one more possibility. And other things, other infections like infectious hepatitis, infective endocarditis, tropical fevers, brucella, EBV, and CMV. So apart from infections, lymphoproliferative disorders are the second important reasons for such a presentation. And we should not forget about granulomatous conditions like sarcoid, and especially in such young males, autoimmune conditions like SLE can present like this. And rarely hyperthyroidism can also present in such a case, but he doesn't have any peripheral signs of thyrotoxicosis. So he was initially worked up outside. He was admitted for 10 days. The initial investigations outside showed CBP showed pancytopenia. His CRP was positive. There was some renal involvement. Creatinine was 2.1. His LFT was deranged. There was direct hyperbilirubinemia with bilirubin of 6.4 and raised liver enzymes, SGOT more than SGPT, and raised alkaline phosphatase. His ultrasound abdomen showed hepatosplenomegaly. His chest X-ray showed bilateral mild pleural effusion. He was worked up for routine fever panel. All tropical HAV, HEV, IgM, and viral markers were negative, except he was found to have typhoid IgM antibodies positive. His blood and urine cultures were negative. So he was treated initially with cephalosporins. In view of persisting fevers and pancytopenia, he underwent bone marrow aspiration outside. It showed just reactive marrow. His ANA was negative. So with this, we could narrow down our provisional diagnosis with the outside investigations and his presentation. Again, disseminated tuberculosis is a possibility. Retroviral disease is ruled out. Infectious hepatitis and infective endocarditis we can still think of. EBV, CMV, and one more thing we could think of is a partially treated typhoid fever. And lymphoproliferative disorder and sarcoid and autoimmune conditions are also considered. So he was outside treated, and in view of worsening LFTs, he was referred to AIG. So in AIG, initially, day one, he was worked up. Some preliminary investigation showed pancytopenia similar to outside. The peripheral smear showed no atypical cells. His procal was significantly elevated, 34, and he had AKI, creatinine of 2.3. There was direct hyperbilirubinemia. Bilirubin went up until 15 with raised liver enzymes, SGOT more than SGPT. His PT-INR was normal. He has positive CRP. Urine examination was normal. His TSH was low, but T3, T4 was normal. ACE was negative. So other infection workup, we have repeated set of investigations. His sputum gene expert was negative. There were few gram-positive coca and gram-negative bacilli. Viral markers were negative. Anti-HAV, HEV was negative. Tropical workup was negative. Brucella was negative, and blood and urine cultures were pending on day one. The chest X-ray showed bilateral mild pleural effusion, right more than left. Ultrasound abdomen showed hepatosplenomegaly. His 2D was normal, ruled out, and which can ruled out infective endocarditis. So his ANA and AMA was negative. So surprisingly, because of high fevers, we have worked up some inflammatory markers. He had almost kind of cytokine storm. His ferritin was more than 1 lakh. LDH was near 3000, CPK 1000, and triglycerides were elevated, and fibrinogen was low. So with this biochemical picture of hyperinflammatory condition features of HLH, we have asked for a bone marrow examination, which showed HLH. So simultaneously, we have worked up for EBV and CMV PCR because of his, liver dysfunction and lymphadenopathy and prolonged fever. I would like to call our pathology colleague, Dr. Vishnu, to discuss about the pathology slides of bone marrow.
Good morning, sir. Moving on to the peripheral smear, we got predominantly normocytic normochromic, WBC are within normal limits, and platelets are decreased on smear, and few giants are seen. In bone marrow aspiration, it is predominantly normoblastic erythropoiesis and orderly maturation of myeloid series, and there is a hyperplasia of megakaryocytes. Whereas in bone marrow, here we can see there is prominence of histiocytes, and at one histiocyte it is showing phagocytosis of there is neutrophils, lymphocytes, and erythrocytes. In bone marrow biopsy, it is showing normal bony trabeculae, and intervening marrow is showing 60 to 70% cellularity, and there is trilineage hematopoiesis is normal, and there is marked proliferation of histiocytes and few plasma cells. And we did PA stain, there is showing marked proliferation of macrophages. So based on the clinical features and bone marrow aspiration and biopsy finding, we gave final diagnosis of secondary hemophagocytic lymphohistiocytosis. These hemophagocytosis were graded on bone marrow aspirate by using the criteria as mild, moderate, severe. When mild is when there is less than 2 histiocyte with hemophagocytosis per slide, moderate 2 to 5 histiocyte with hemophagocytosis per slide, and severe there is greater than 5 histiocyte with hemophagocytosis per slide. In this case, we have severe hemophagocytosis. So moving to Dr. Kiran.
So he has severe phagocytosis on bone marrow. It was suspected to be a secondary because he had outside salmonella positive. And in adults, secondary HLH is more common than primary HLH. Primary we see in pediatric population. So he has a life-threatening. He presented with a PO which turned out to be HLH. As per this HLH criteria, which is latest, he had fever, splenomegaly, cytopenias. He had hepatitis. He had high ferritin. He had hemophagocytosis seen on bone marrow. He had other supportive features like hypertriglyceridemia, high ferritin, low fibrinogen. So what is HLH? HLH, it's not a diagnosis. It's a manifestation of something. It could be still an infection, a malignancy, or an autoimmune disorder. So we have started him on broad spectrum antibiotic initially after initial stabilization. So we have further worked up in view of we didn't have a confirmed clue what is causing his condition. So we went ahead with a whole body PET CT scan because we don't have any positive infection workup, and bone marrow showed just HLH. No other bone marrow gene expert was also negative. So PET CT scan showed multiple lymph nodes above and below diaphragm with hepatosplenomegaly. First possibility was suspected COX on PET CT, and second thing was lymphoproliferative disorder. Largest lymph node was 1.6 by 1.2 centimeter on the left level 2 cervical lymph node. So it was considered for a lymph node biopsy. There was no abnormal metabolism elsewhere. So excision biopsy of left cervical lymph node showed atypical lymphoid infiltrate. A possible lymphoproliferative neoplasm was suspected and suggested IHC. So waiting IHC, we got final blood culture and urine culture reports which were negative. CMV was negative. Surprisingly, EBV found to be nearly 60,000 copies per ml, suggesting EBV viremia. So after that, we got a IHC report next day. It is confirmed to be a case of a T-cell lymphoma, anaplastic large cell T-cell lymphoma. So with this, we could come to a final diagnosis. He had EBV viremia, probable secondary HLH because of EBV, or due to lymphoma. So, what is the correlation between all these three? So, EBV can cause, it's known to cause B cell neoplasm like Hodgkin's lymphoma, but T cell neoplasms are not uncommon, and especially in immunodeficient patients, T cell lymphomas are very common. And how lymphoma, in a case of lymphoma, EB, because of low NK or T cell activity, EBV infections are recurrent, and EBV is known to cause HLH, and its most common cause for HLH is in infections is EBV, and in a case of, and it's a secondary HLH. So in a case of primary HLH is it's seen in genetically predisposed individuals. Fatal EBV infections are common, and just like mentioned, T cell lymphomas can also cause HLH secondary. So with this, does he have any immunodeficiency? His immunoglobulins workup was negative, and still even in adults we have to think of primary HLH because of he had fatal EBV, he presented with HLH. So we have sent for a genetic test, clinical exome sequencing for primary HLH, which we got, which the report of which we got last night. So I will request Dr. Bala Saib, our hematology colleague, to discuss about the treatment part.
Good morning, everyone. Sorry, we presented this case very slowly here, but on the ground in ICU, this was like medical emergency. Everybody was involved, and we were very curious because patient was totally flushed. Full tachycardia was there, 150. We never knew when the patient is going to have a cardiac arrest or going to get intubated. So I remember this case was admitted on the Friday early morning, and within a span of 48 hours, we did a PET CT, lymph node biopsy, bone marrow examination, and arrived at the diagnosis of sepsis and HLH. So we patient was already on treatment for sepsis, as procalcitonin was high. He was on broad spectrum antibiotic. That part was getting covered. So as soon as HLH was confirmed, hemophagocytes were seen on the bone marrow. We started treating with high dose steroid, and after starting steroid, his symptoms of SIRS had come down. We did a biopsy on Saturday late evening, and a biopsy Monday morning we got a report that it is morphologically looking like lymphoma. So we went ahead and treated EBV also. After consulting infectious disease people, they suggested to give acyclovir, and subsequently we given rituximab for B cell suppression and IVIG. On the Friday, after about 5 days, anaplastic large cell lymphoma was diagnosed, and we started him on etoposide. So the purpose of treating HLH is we have to handle a cytokine storm. For that, we gave steroids and etoposide. He was on prophylaxis for PCP and HSV. Presently, the patient is on a second cycle of chemotherapy. Further treatment plan for this patient is continue 6 cycles of chemotherapy followed by autologous stem cell transplant. The next gene sequencing which we had done, Dr. Kiran mentioned in the previous slide, that has come negative. There is no component of primary HLH. So this is all secondary HLH. This is all secondary HLH, secondary to lymphoproliferative disorder. The last Grandround, if you remember, we had a case of primary HLH who was a small kid that evolved over the period of time. It took 3 weeks for us to diagnose. This case was like, it was giving all the clue that there is a diagnosis, and we had arrived at the diagnosis within 48 hours of the time. Present status of the patient, he is on follow-up. He has completed 2 cycles of chemotherapy. Liver function is totally normal. There is no cytopenia, and ferritin is less than 2,500. Dr. Kiran will give us further details.
Thank you, Hematology, Pathology, and especially ID team. We take much help from Dr. Bala Sahib sir nowadays. So subsequently his EBV was undetectable in the hospital course, and his cytopenias and LFTs were improving, and he's on regular follow-up before chemotherapy with Dr. Bala sir. So just brief about pathogenesis of EBV. It spreads by oropharyngeal secretions. It's called a kissing disease. It infects B cells in the lymphoid tissue, and the EBV infected B cells replicate. The thing is, uncontrolled replication of EBV infected B cells lead to transformation to malignancy, and in EBV cellular immunity is more important than humoral immunity in curtailing the infection. So the clinical syndromes it can present as infectious mononucleosis. It can present as tumors and infection in immunocompromised patients like HIV, organ transplant on immunosuppression. So what is infectious mononucleosis? It's also called glandular fever. Worldwide, 90% of children get infected in their early childhood. The infection goes asymptomatic.
Kiran, can you summarize, please? We have little time for the third case. You have one more case.
So it can present as fever, lymphadenopathy, pharyngitis, enlarged spleen, hepatomegaly, and they can have atypical lymphocytes on peripheral smear. The complications of EBV are because of pharyngeal obstruction, upper airway obstruction, splenic rupture, meningoencephalitis, and Guillain-Barré syndrome. It's known to cause tumors like mostly B-cell lymphomas like Burkitt's lymphoma, especially in Africa. Most common tumor associated worldwide with EBV is gastric carcinoma, and NK and T-cell lymphomas are rare but not uncommon. So this is the genetic test which we got last night. It doesn't show any mutation. Thank you.
Dr. Vijay Mohan.
The infectious mononucleus, we call it as mono, very self-limiting disease, and it runs a very low clinical scenario in many patients. Sometimes it may be undetected also. But in this unfortunate patient, he had hematological complications, and rightly have diagnosed the right cause of the disease and treated the case properly. One word about PO. Sir.
No, go ahead.
One word about PO. In spite of all the investigation, even till today, 25% of the patients still undiagnosed. So, though in India we have to repeat a malaria test every 6th hourly for 48 hours, and tuberculosis also sometimes may be undetected. We have to sometimes empirically anti-malarials, anti-tuberculosis are allowed in some books. Thank you.
Thanks. Just a quick question. What is the temporal profile between EBV infection and lymphoma? Because this is a very quick transition that occurred in this patient. How long does it take for this to come?
It's not clearly known, sir, but especially in patients who are immunodeficient, EBV infections are known to cause a fatal like lymphoproliferative. So this infectious mononucleosis like EB infection, common infection, it has like 2 to 4 weeks of this thing. So in that, yeah, lymphoma also can happen in that time.
I think this is very important. EBV has a historical significance for such of you who are interested in Emperor of Maladies. This is one of the first virus which has been associated with tumor, oncogene, and Burkitt's lymphoma, which has been localized. So it's a lot of historical significance. The answer to the question is this leads to persistent infection and B-cell proliferation, which in turn rarely can trigger, it can traditionally be associated, I think Balasaheb will be better to explain, traditionally with B-cell lymphoma because of persistence, but in some people that is mopped up by T cells and can trigger T-cell lymphoma. That's a less prevalent disease, probably you can clarify.
EBV is most commonly seen in B-cell malignancies, and it can trigger the malignancy within span of time. Like Burkitt's lymphoma can be very aggressive, and other lymphomas like B-cell lymphoma can develop over the period of 2 to 3 months. Basically, it's a B-cell suppression followed by chronic antigenic stimulation leading to the lymphoma.
Thank you for the interesting case. Again, in the work of a PO, it's to say it's a Sutton's law. I think it's way back it has been said. Go where the money is. So when you have a person with lymph node enlargement, hepatosplenomegaly, there is an intense reticular endothelial activation. So you need to go to the marrow or where you are likely to get the diagnosis fast rather than doing several hundred things, because in our country, by the time you do all these investigations, your bill is 2 lakhs, patient cannot afford a bone marrow biopsy. So that is, you need to be cognizant of this. Don't keep on investigating. You are a good clinician. You go where the money is, establish the diagnosis and start treatment. I'm glad that was done. And I would like to see the emphasis, the speed, especially on a weekend. If you have a meningitis, you need a CSF diagnosis within few hours. Otherwise, the patient is dead and gone. You can't wait for the weekend, Monday result, Tuesday result. So this is very, very important when you handle these emergencies. Thank you for the nice presentation. We'll have the next presentation, please.
Good morning, all of you. I'll start here with my presentation of a 56-year-old male who presented to us with complaints of low-grade fever with repeated drop in his hemoglobin despite having transfusions since around 1 week. In the past history, he had undescended testes for which he received some chemo, probably progressed to a germ cell tumor. The full details of that were not available. He had a traumatic fracture of his right leg and he was recently detected as diabetes and finished with his 2 doses of COVID vaccine. According to him, his hemoglobin 3 years back was normal, and we couldn't find any negative history to give us any clue to the diagnosis. So on examination, he was slightly tachycardic with around 120 pulse and a white pulse pressure with a low-grade fever of around 100. His respiratory rate was around 26 per minute with saturations with 96. There was a pallor and icterus, and keloid scars were there over the chest, hands and feet. On general and systemic examination, there was no clue, no lymph nodes and no organomegaly was present. So considering his acute drop in hemoglobin with anemia and jaundice, we thought it could be a hemolytic process. There could be a chronic inflammation and autoimmune conditions, any blood loss, any infections, including HIV, myelo and lymphoproliferative disorders, along with paraproteinemias. So if we have a case of anemia along with the CBC and retic count, we look for the index and categorize them with the red cell morphology, where it is falling into a hypoproliferative maturation disorder and hemolytic process. And based on that, once the subsequent categorization is done, we proceed accordingly. So here in his overall general labs, he was found to have a hemolytic process where there was microspherocytes along with focal agglutination of RBCs, which was suggestive of hemolysis. Reticulocyte count was high with low haptoglobulin and Coombs came as 4+. USG abdomen was showing splenomegaly of around 13 centimeter with no gallstones, which suggests that it is probably an acute to subacute process rather than chronic. So these are the lab findings that we find in somebody who is having a hemolysis, where you find that there is decreased hemoglobin along with increased retic count, increased LDH with increased indirect bilirubin and decreased haptoglobulin levels, along with hemoglobinemia and hemoglobinuria. The subtle clue in intravascular hemolysis that you can find that your CUE will show plenty of blood, but there will be no RBCs. That can probably give us a clue that it is a intravascular hemolysis. And peripheral smear is the gold standard, which will clinch us the diagnosis. So since we confirmed that it is hemolysis, our next job was to see whether it is a extravascular or intravascular hemolysis. So intravascular hemolysis, it is within the circulation, so you will not find any extravascular workup. And if it is extravascular, the reticuloendothelial system will come into the picture. So you will have hepatosplenomegaly along with bone pains and bony tenderness. So when we started working up, we also worked up on the infection side along. So we concluded it is mostly an extravascular hemolysis. And then the next point is whether it is some genetic or acquired defects. So we thought the genetic, since he's a 56-year-old, the other hereditary pathologies were out of the picture, and we thought it is probably an immune mediated hemolysis. So his infection workup was negative, his CTD workup was negative, and he didn't have any evidence of any blood loss. And dermat consultation for the keloid scars were done, which showed that it is chronic plaque psoriasis with a keloid formation. So these are the drugs which can cause hemolysis. He didn't receive any of these drugs prior to this episode. So again, coming back to our differentials, we successfully excluded that it is not autoimmune. There is no blood loss. There is no infection, including HIV. So now we left with immunohemolytic anemias, myelo and lymphoproliferative disorders, and paraproteinemias. So he went with serum protein electrophoresis, which showed an M band, and immunofixation studies suggested that it is a monoclonal gammopathy with undetermined significance. Subsequently, to look for myelo and lymphoproliferative disorders, we did a marrow and a biopsy along with lymphoma panel, which came as negative. So these were the patient reports. To give us a little bit more insight on this protein electrophoresis and its interpretation, I would like to call Dr. Deepika Madam from the Biochemistry Department to give us a brief idea on this.
Good morning all. So slightly basics of protein electrophoresis and the line of investigations which are required for this type of cases, I'll be focusing. So protein electrophoresis, we know it refers to migration of charged particles in a specific medium under the influence of electric field. This technique used to separate proteins based on their net charge, size, and shape. So we have types of electrophoresis, zone electrophoresis, and moving boundary electrophoresis. In our institute, we'll be doing agarose gel electrophoresis, then we'll be doing capillary electrophoresis and immunoelectrophoresis. So capillary electrophoresis, it uses a very less diameter glass tubes, and the sample is injected into a capillary with a negative surface charge, and a high current is applied, which is separates depending upon the electrophoretic mobility and electroosmosis. So advantages of this test are it's a high speed and high resolution. The electrophoresis this is approximately in the total protein. We have 60% of albumin, which is showing a highest peak, and from positive anode to cathode, it will be like alpha 1, alpha 2, then this is beta 1, beta 2, and gamma. So most commonly from the gamma is the globulin, where we'll be looking for monoclonal gammopathies and the polyclonal type. So in this case, we found an M band of 0.6 grams per deciliter in the gamma region. And the free light chain quantification, where this is done by the turbidimetric and nephelometric methods. In this case, we have seen a kappa lambda in free light chain is the kappa lambda ratio. This is the kappa lambda ratio was high in serum and urine. This is the nephelometric what we use in our institute. This is recommended by the International Myeloma Working Group. So in this case, we have seen a kappa lambda ratio of high. So this is the immunofixation technique what we use. We have electrophoretic tank, battery, backpack, gel scanners. This is the technique what we use in immunofixation electrophoresis. We dilute the patient sample and it is applied to each track of the gel using an application mask. The gel is electrophoresized, separating the proteins according to their charge. Then we add protein fixative is added, and in this immunofixation, we'll be looking for heavy chains and light chains, which is qualitatively analyzed. And this IgG, IgA, IgM, and the light chains kappa and lambda are applied to the gel. During incubation, they form insoluble immune complexes of the gel is now washed, it's pressed, dried and stained. The samples are examined for paraproteinemias in total in this protein electrophoresis and IgE tracks. So in this case, we have seen a spillage of, in the kappa region, we saw the spillage of free monoclonal light chains. So where we need to use the urine protein electrophoresis and 24 hours urine immunofixation is in the conditions where you have a monoclonal protein and the serum is greater than 1.5 grams per deciliter, and in monoclonal free light chains, which is detected in serum and in hypogammaglobulinemia, and in cases where the nephrotic pattern. It also be used in amyloidosis cases and in monoclonal gammopathy of renal significances. These has to be. Then in case of abnormal serum protein electrophoresis, if you have a less than 1.5 grams per deciliter, this has to be followed annually. And if it is between 1.5 to 2.5 grams per deciliter, we need to go for kappa lambda quantification, then 24 hours urinary protein electrophoresis and immunofixation. If it is normal, then the follow-up of protein electrophoresis should be 3 to 6 months. And if it is again normal, you have to annually check the patient. If it is an abnormal thing, then you have to refer to the hemato-oncologist. If it is more than 2.5 grams per deciliter, then you have to look for metastatic bone surveys, aspiration and biopsy of bone marrow, then abdominal CT, beta 2 microglobulinemia, globulin, C-reactive protein levels, and again the 24 hours urine protein electrophoresis and immunofixation along with the kappa lambda chains. So kappa lambda chains, they are used for diagnosis, for monitoring of the patient, and also for the follow-up of the patients and the prognosis also. And in this case, if it is normal, then again you need to recheck after 2 to 3 months. And if it is again normal, again after 3 to 4 months. And if it's normal, it has to be checked annually. If it is abnormal, it has to be referred to the hemato-oncologist. So the sensitivity, specificity of this test, the order of test should be the serum protein electrophoresis, if along with the free light chains, if it is added, then in plasma cell disorders, with only serum protein electrophoresis, it is 79%, and only with the free light chain, it is 74%, and together with the serum protein electrophoresis with immunofixation and free light chain, it goes to 97%. In multiple myeloma cases, it is only protein electrophoresis is 88% and free light chain is 96%. And together with the three protein electrophoresis, immunofixation and free light, it will be 100%. In amyloidosis cases, it is 66%. In the protein electrophoresis, generally sometimes you won't see in protein electrophoresis, serum protein electrophoresis. Then you have to ask for free light chains, which gives you 88%. And together, it gives you 97%. And in light chain diseases, it is only 56% you see in protein electrophoresis, and free light chains at 78%, and together it is 78%. So in this light chain diseases and amyloidosis cases are in monoclonal gammopathies of renal significance. We require urine protein electrophoresis, which will increase your sensitivity along with the serum testing. So in this case, it is a light chain monoclonal gammopathy of undetermined significance, which had a M protein of less than 3, and the bone marrow showed less than 10%, and there were no CRAP symptoms. Ketan.
Thanks a lot, ma'am. So basically, MGUS is a monoclonal paraprotein without any end organ damage. Why it is important? It is somewhat like a pre-malignant condition where it needs constant follow-up, because it may transform into multiple myeloma. And here, when there is an active hemolytic process going on, so tomorrow if it drops his hemoglobin, we need to
Can you summarize, please? We are running short of time.
So he was started with he was stabilized with 2 units of transfusion and started with prednisolone, and he developed his response, after which but we cannot have a response and sustained remission, so it also needs a second line treatment. So give a brief idea on the second line treatment. I would like to call Dr. Balasaheb sir to give us more idea on that.
Thank you, Dr. Ketan. We had Dr. Ketan and medicine team had treated the patient with steroids, but he was not responding. So further options we gave was azathioprine, cyclosporine, and rituximab. There are other agents for any autoimmune hemolytic anemia secondary to other conditions like PNH. We use alemtuzumab and all. I would not discuss that. After he was treated with azathioprine, but azathioprine subsequently stopped because of cytopenia, and then we had to start him on MMF. On MMF also he had relapsed within 8 weeks. So option of rituximab was given, and currently patient has received 4 doses of rituximab and he is in complete remission on follow-up. So these are the third line agents we use in the autoimmune hemolytic anemia: rituximab, splenectomy, high dose cyclophosphamide. In desperate condition we use plasma exchange, IVIG, or alemtuzumab in case of PNH. Thank you.
We'll have comments, brief comment, and then we'll Dr. Vijay, please.
So, when do you get these Benz Jones in urine? Only when the light chains are dominating in myeloma, or all cases of myeloma? Sometimes you don't get positive. Usually we ask for the urine for the BJ proteins. What I understand is only when light chains are dominating you get positive, otherwise it need not be positive in all cases.
There are criteria developed by International Myeloma Working Group. The light chain can be increased, but there has to be a ratio. If it is a ratio less than 0.6 and ratio of kappa lambda or more than 1.6 is considered as monoclonal. That monoclonality is determined by immunofixation electrophoresis. That also is important, because in CKD we might get deranged parameters of the free light chain.
Thank you. I think it presents differently for us in common garden variety when you're sitting in the OP. Common thing where you suspect is when the globulins are high, patient has mononeuritis, patients with the postural hypotension. These are all typical manifestations we need to go and investigate. They may not, relatively may have everything normal, but we see these patients with lot of atypical manifestations. We had very good interaction. I would like to thank Dr. Vijay Mohan.
One last point, sir, last point from my side. Regarding PO, as a clinician, I would like to auscultate the patient and suppose there is a murmur, I can think in terms of some chronic infected endocarditis or an ECG. There is bedside clues that can give you a direction of where to go, how to investigate, and especially when you are dealing with PO and other cases. Thank you very much.
Thank you.
Thank you very much. I'd like to thank the internal medicine department for these very interesting cases. Dr. Vijay Mohan for moderating this. I think this is again very good lessons about multi-speciality to us, and I was especially impressed with the second case, like Dr. Narasimham said. Over the weekend, there was a diagnosis of very complex disease, HLH with EBV, with lymphoma coming together. I think this can happen only in AIG. We are proud that these things are happening, and that the patient, of course, got, I think, the benefit of the diagnosis and the treatment, and of course, resolved because of this. Thank you once again, and our next grand rounds would be April 5th next month. Thank you.